You know, when someone gets knee surgery, they're obviously hoping for relief. But for so many people, what comes next is a whole new kind of mystery pain. It's this super common story. The surgeon says the operation was a success, the joint is perfect, but the pain? It's somehow worse than ever. So today, we're going to pull back the curtain on this medical puzzle and find the hidden culprit.
And this quote from the journal, Pain Physician, really just nails it. It's not just the patient who's at their wits' end. This is a true puzzle for doctors, too. Everyone is left scrambling for answers that are, frankly, really hard to find.
To make this all feel a bit more real, let's talk about a man named RB. He's 79, he gets a total knee replacement, the kind of operation that's supposed to give him his life back. But 6 months later, the complete opposite happened. He was stuck in a wheelchair, dealing with crippling pain. He is the perfect example of this frustrating mystery.
RB's story is really our doorway into this whole thing. How could a surgery that was technically perfect lead to such a terrible result? His case forces us to look beyond the shiny new joint and start hunting for a completely different kind of problem.
And when you look at his symptoms, you can see this was way more than just a dull ache. His knee was visibly swollen, red and warm. The pain was so bad he couldn't even bend his leg. And his skin got so sensitive that the lightest touch was pure agony. There's a name for that. It's called allodynia. So at first, they diagnosed him with something called complex regional pain syndrome, or CRPS. But the really frustrating part? The standard treatments for it did absolutely nothing through him.
So the failure of that initial diagnosis really forced his doctors to think outside the box, to look deeper. It became pretty clear the problem wasn't the new knee at all. It was a nerve. So let's meet this hidden culprit.
Okay, so here it is. It's called the infrapatellar branch of the saphenous nerve. Let's just call it the IPS nerve for short. It's this tiny little sensory nerve that runs across the front and inner part of your knee. Its one and only job is to send sensation signals from the skin there back to your brain. That's it.
And this right here is why this little nerve is such a big problem. Its path isn't the same from person to person. It's highly variable. Sometimes it goes right through a muscle. Other times it wraps around it. And this anatomical lottery makes it incredibly easy for a surgeon to accidentally damage it during a knee operation, whether it gets stretched, nicked, or even just trapped in scar tissue later on.
So what happens when that vulnerable nerve gets hurt? Well, it creates symptoms in a very specific pattern. And this math here shows that classic distribution of pain for an injured IPS nerve, that burning, tingling feeling right below and to the inside of the kneecap. For RB, this wasn't just close. It was a perfect match.
The best way to wrap your head around this kind of nerve pain is to think of it like a faulty fire alarm. The fire, which was the surgical cut, is out. The knee is all healed up. But the alarm system, that damaged nerve, is just stuck, blaring nonstop pain signals to the brain 24/7.
Okay, so understanding that the nerve could be the problem is one thing. But how do you actually prove it's the cause? Well, this is where the real detective work begins. We're going to look at how doctors crack the case and confirm a diagnosis of IPS neuralgia.
It really just boils down to a pretty clear 3-step process. First up is a hands-on physical exam. Second, they take a look inside using modern imaging. And third, the final test, the real confirmation, is something called a diagnostic nerve block.
Step 1 is often the simplest. A doctor can just gently press or tap along the path where they think the nerve is. If that simple touch sends this zinging electric shock-like feeling down the nerve's path, boom. That's called a positive Tinel sign, and it's a huge clue that the nerve is irritated.
Next, they can use ultrasound to actually see the nerve directly. Now, these images can be a little tough to read if you don't know what you're looking at, but they're incredibly valuable. On the left, you see what a healthy nerve looks like, but on the right, well, that's the problem. The area marked by the arrowheads shows this tangled up, swollen, and painful bundle of nerve tissue called a neuroma. This tech lets them literally see the source of the pain.
But for RB, this was the moment that changed everything. The doctors injected just a tiny bit of numbing medicine right where they suspected his nerve was injured. And the result? It was immediate. It was dramatic. The quote says it all. Within just a few minutes, 6 months of agonizing pain just vanished. And he could walk without any trouble. By temporarily shutting off that faulty alarm, they proved it was the source of the problem all along.
And RB's story is not a fluke, not even close.
One study found that for patients who have that positive Tinel sign and a knee that's otherwise stable, a staggering 90% get major relief from this diagnostic block. It is an incredibly reliable way to lock in the diagnosis.
So, confirming the diagnosis is that huge breakthrough moment. But the real goal is lasting relief, right? So, once the IPS nerve is identified as the bad guy, what's next? Let's look at the ways to get patients like RB back on their feet for good.
There are a few main strategies here. Sometimes those diagnostic injections, especially if they add a steroid, can provide long-lasting relief on their own. But for more stubborn cases, the two main options are something called cryoneural ablation, which is basically freezing the nerve, and a neurectomy, which is surgically removing the damaged part of the nerve.
Now, cryoneuroablation is what RB got, and it's a really fascinating technique. A tiny probe is guided right to the nerve, and then extreme cold is used to form a little ice ball around it. This doesn't permanently destroy the nerve structure. It just temporarily shuts down its ability to send those pain signals. This gives the nerve a chance to heal and regenerate properly over the next few months, all without that constant, screaming pain. And for RB, this was the final piece of the puzzle. With that non-stop, overriding pain finally silenced, he was actually able to do his physical therapy, rebuild his strength, and get the mobility his knee replacement was supposed to give him from day one. He finally got his life back.
So RB's story is such a powerful example of what can happen when you find the right diagnosis. But his case also points to some bigger truths about post-surgical pain and how we should be thinking about it. So let's kind of pull all this together into some key takeaways.
And this is a really important layer to add. Research shows that the patients who get lasting relief from these nerve treatments usually have two things in common. You can clearly see nerve damage on an ultrasound, and their knee joint is stable. Now, on the other side, the people who don't respond as well often have an underlying mechanical issue, like knee instability. So the nerve pain is real, but it might be a symptom of a bigger structural problem. It just goes to show you really have to look at the whole picture.
So what does all this mean for you? Or maybe for someone you know dealing with this? Well, number one, that nagging pain after surgery is real. It is not all in your head. Number two, a very specific and, more importantly, a treatable nerve injury could be what's causing it. 3, that diagnostic nerve block is an incredibly powerful tool to find out for sure. And maybe the biggest takeaway is this. You have to advocate for a full, comprehensive evaluation that looks beyond just the joint to consider both nerve issues and the overall stability of the knee.
And that leaves us with this final, really big question to chew on. When you think about how common knee surgery is, and how often this little nerve is right there in the surgical field, you just have to wonder, could bringing this one often overlooked nerve out of the shadows completely transform the recovery experience for millions of people? It's a pretty powerful thought.